Welcome to this rapid-fire explainer. Today, we're building your ultimate mental cheat sheet for mastering tongue pathology. Whether you're in the trenches prepping for your board exams or you just want a heavily structured, detail-oriented review, we've got you covered. We're basing today's framework entirely on Dr. Mohammed Al-Daharo's essential classifications. My goal here? To help you file away every single granular detail so you can instantly recall it under pressure. Let's get into it. But hey, before we even look at the agenda, let's activate your recall with a classic board exam question. Which syndrome is classically associated with a scrotal tongue? Keep your answer in mind, or just take a guess right now, because we're going to uncover the exact answer a bit later on. Okay, here's our agenda and the taxonomy we'll be using. Memorize these 5 categories right now to build your overarching framework. 1. Anatomy and function fundamentals. 2. Inherited and congenital anomalies. 3. Disorders of lingual mucosa. 4. Body of tongue diseases. And 5. Tumors of the tongue. Starting off with Section 1, Anatomy and Function Fundamentals, the baseline. Look, we have to start our structural tree by grounding ourselves in normal anatomy before we can even touch on pathology. You literally can't diagnose a variation if you don't know the baseline, right? Take a look at this muscular foundation sitting right in the floor of the mouth. You'll specifically want to note the transverse and vertical muscles. These are what give the tongue its incredible multi-directional mobility. It's a highly complex organ, and any disruption to these fibers is absolutely going to present clinically. Now, beyond the obvious mechanics, chewing, swallowing, speech articulation, and being the primary organ of taste, the tongue is actually your high-yield diagnostic mirror. It doesn't just show local oral diseases. It's a critical indicator of broader systemic issues taking place throughout the patient's entire body. Moving on to Section 2, Inherited and Congenital Anomalies. This is our first branch of pathology. Let's break down these developmental anomalies into 2 distinct, highly testable categories. This table right here is a literal lifesaver for your exams. By contrasting minor developmental variations against major structural ones, you create a perfect mental cheat sheet. Minor variations include things like partial ankyloglossia, tongue thrusting, and fissured tongue. On the flip side, major variations are severe developmental alterations. Think a completely cleft or bifurcated tongue, massive size differences like macroglossia or aglossia, and major surface defects. Filing these into minor versus major buckets, that's going to help you instantly eliminate wrong answers on multiple choice questions. Let's pull out one specific minor variation for clinical focus, the domino effect of tongue thrusting. The crucial takeaway here is that a minor variation like tongue thrusting doesn't just affect the tongue itself, it actually cascades into structural dental issues. This is a classic board scenario where a tongue issue presents as a full-blown orthodontic problem. So if you see a case study presenting with bimaxillary protrusion or an anterior open bite, you've got to immediately suspect tongue thrusting as the underlying mechanism. The constant, repetitive physical pressure cascades into issues like proclination of anterior teeth, anterior and posterior open bites, and posterior cross bites. Basically, the muscle physically remodels the patient's bite over time. Wild, right? Now let's tackle that quiz question from the beginning by defining the fissured tongue. First off, you absolutely must memorize all of its synonyms: scrotal tongue, plicated tongue, and lingua dissecta. Exam writers love to use these interchangeably just to trip you up. It's characterized by furrows extending anterior-posteriorly and laterally. The clinical significance here? Well, these fissures retain bacteria and debris, which leads to a really uncomfortable burning sensation and irritation for the patient. Burn this clinical presentation into your memory. Here's the ultimate high-yield fact to answer our earlier question. Fissured tongue is highly associated with trisomy 21 and Melkersen-Rosenthal syndrome. If a question gives you a patient with facial paralysis, lip swelling, and this exact tongue presentation, that is Melkersen-Rosenthal until proven otherwise. As for management, it's simple but essential. Rigorous oral hygiene to keep those deep fissures clean. Section 3, Disorders of lingual mucosa. Let's see how mucosal surface changes dictate our diagnostic approach. We're not talking about development anymore. We're strictly talking about the surface tissue. Memorizing this table and separating keratotic white lesions from non-keratotic ones is a guaranteed way to crush test questions. Keratotic lesions, meaning they have a thickened layer of keratin, include lichen planus and leukoplakia. Non-keratotic lesions include candidal thrush, white sponge nevus, and various vesiculobullous or desquamative disorders. The golden rule: if it wipes off, think non-keratotic, like thrush. If it doesn't budge, start thinking keratotic. Beyond just the white lesions, you've got to categorize mucosal disorders into 4 other distinct buckets. First, changes in the papillae itself. This gives you geographic tongue or a coated, hairy tongue. Second, pigmentation anomalies. Third, specific ulcers and infectious diseases. And finally, superficial vascular diseases that pop up right on the mucosal surface. Within this mucosal branch, we also see deep papillacean and atrophic lesions. When you're looking at a bald, deep papillated tongue, you can't just look at the mouth. You've got to rapidly run through a specific checklist of systemic causes to figure out exactly why the surface is wasting away. You'll want to step through this exact sequence in your mind when evaluating an atrophic tongue. Step 1, check for basic chronic trauma or nutritional deficiencies. Step 2, run blood work for hematological abnormalities or do a thorough medication review. Step 3, rule out peripheral vascular disease. Step 4, screen for underlying diabetes and chronic candidiasis. And finally, Step 5, test for severe systemic infections like tertiary syphilis leading to interstitial glossitis. Follow this checklist, and I promise you, you won't miss the underlying systemic driver. All right, moving on to Section 4, Body of Tongue Diseases, our third pathological branch. We've thoroughly covered the surface mucosa, so let's dive deeper into the diseases affecting the actual deep muscular body of the tongue. Unlike surface lesions, these conditions fundamentally alter the structural or neuromuscular integrity of the tongue itself. We're talking about systemic deposits like amyloidosis, deep tissue infections, profound neuromuscular disorders, and vascular diseases of the tongue body. It even covers functional conditions tied to the tongue's mass and position, things like sleep apnea syndrome, TMJ myofascial dysfunction, or sudden rapid swelling from angioneurotic edema. If a patient presents with a physical mass projecting from the deep tissue, like a lateral nodule, you have officially moved out of the mucosa branch and into the body disorders branch of your cheat sheet. The diagnostic approach totally shifts here, going from simple surface swabbing to deep tissue imaging or biopsy. And finally, Section 5, Tumors of the Tongue, our final branch. This classification is brief, but clinically it is absolutely the most critical when dealing with pathology. Tumors of the tongue simply subdivide into 2 life-altering diagnostic categories, benign versus malignant. When you find a true neoplastic growth, visual inspection just isn't going to cut it anymore. The standard of care requires an immediate histopathological biopsy to distinguish between the two. Why? Because a malignant tumor in the highly vascular, highly mobile tissue of the tongue requires immediate, aggressive intervention. All right, before we wrap up this explainer, let's cement your mastery. Close your eyes for a second if you need to. Can you actively recall the baseline anatomy plus the 4 main pathological branches we just used to categorize every single tongue disease? Here is your final mental architecture. 1. Inherited, congenital, and developmental anomalies. 2. Disorders of lingual mucosa. 3. Disorders of the body of the tongue. And 4. Tumors. If you can hold this exact structure in your mind, you've successfully built the ultimate cheat sheet for your board exams. You literally now have a mental filing cabinet for any tongue pathology thrown your way. So next time you look at a clinical case, ask yourself, which of these 4 branches does this belong to? You see, the tongue doesn't just help us speak. It's quietly telling the story of the patient's entire systemic health. The real question is, are you fluent enough to translate it?